Good morning, sir. Good morning, everyone. My patient is a 54-year-old man, resident of Chiplun, Maharashtra, employed in a desk job at an office, presented with the chief complaints of right groin pain since 1 year and limp since 8 months. The patient was relatively asymptomatic 1 year ago when he developed a dull, aching, insidious onset pain in the right groin, which was present throughout the day, aggravated by activity and relieved by rest, and interfered with his daily activities of ground level activities such as sitting cross-legged or using an Indian washroom. The patient also presented with the complaint of a limp while walking, which was insidious in onset, associated with pain and gradually progressing. And the patient was able to walk without any aids. There was no history of any trauma, fever, cough, any night cries, any morning stiffness, small joint involvements, or any waxing or waning of symptoms. There was no history of loss of appetite, alteration in the bowel bladder activities, or any history suggestive of bleeding disorders requiring blood transfusions, or any surgical intervention, or any childhood incapacitations. The patient had no history of any medical comorbidities such as bronchial asthma, or any dermatological condition, or a chronic renal disorder, or any diabetes mellitus or hypertension. In personal history, the patient has a mixed diet, and there is a positive history of BD smoking since 10 years, but there is no history of any alcoholism, chronic alcoholism, or any chronic drug intake. The patient has no significant family history. I would like to proceed with my general examination.
I think now you should elaborate more on the pain part of it. How severe is the pain? Is it disturbing? Is it disturbing his day-to-day activity? How bad is the activity of daily living it is affected? Is there any work absenteeism? Does he require any drugs for relief of pain? Has he sought any medical advice? Is it taking NSAIDs or painkillers on a regular basis?
Yeah.
What is the functional disability that he has? What is should be covered?
So the patient, the employment is not hampered due to the pain, but he has limitations of ground level activities like sitting cross-legged or using Indian washroom. And he has not taken any medications for the same.
Did he have COVID in the past?
No, there is no history of any COVID infection.
That is now in this
Yes,
present circumstance, it is important.
Yes, sir.
Because what has happened is COVID, many times severe COVID, it is treated with the steroids. Okay, the steroid we know is a known risk factor. And another thing is COVID induces a state of hypercoagulability. So we have seen cases where even without steroid intake, just having COVID itself puts it risk of AVN, similar to say HIV patients. They have slightly higher incidence of having AVN. So similar to that. So COVID is important.
I would just add one more thing.
Yes, sir.
I don't think you spoke about pain on bed bearing. And secondly, you haven't spoken much about pain at rest after activity. So these two are important?
Yes, sir.
Why?
Sir, patient, if there is pain on weight bearing, that would hamper his walking distance, means how much he is able to walk, and that would guide us towards an arthritic hip. So that would be
pain at rest.
Sir, if in this case the pain is relieved at rest, but if there is rest pain also, then it might suggest towards an infective pathology or a inflammatory pathology. If there is pain at rest.
Yeah, otherwise well covered. Yeah.
Okay. I would like to proceed with my general examination.
So in the history present, he has presented a history nicely. You understand that he told about one thing, that whenever you don't tell chief complaints of, you tell complaints of. Okay, patient never tells this is my chief complaint, this is my you only get. So patient complaints of like this, number one. Number two, as he told, whatever complaints, 1, 2, pain and all, that you characterize in the history of present illness. And that you should describe how it progresses, what treatment is taken, and what is the outcome. Or not at present, what is the status. So that you remember those points, and accordingly it should, one should hear like a story that he is presenting. Okay.
So at the end of history, what is your impression?
Sir, at the end of history, I would this seems to be a case of a secondary arthritis, most probably due to a avascular necrosis of hip in a patient with current disability of inactive inactivity to do daily living activities and pain while walking.
Don't talk more.
See,
Okay.
now you're, okay, now I'm going to ask you what are the history features which suggest the diagnosis that you're thinking in terms of?
Sir, the
You said secondary arthritis probably due to AVN.
yes, sir.
So what are the features that you found on his history that suggest this diagnosis?
Sir, mainly the pain on weight bearing and the limitations of the ground level activities, which suggest that there might be an arthritic component. And sir, from the negative history, I could not elicit any other pathology, and that is why I would like to go with avascular necrosis of hip as a most probable diagnosis. But I would like to keep the differential of tuberculosis hip in this condition. That I would like to rule out.
So you have to ask leading questions.
Yes, sir.
Like if you have thought AVN in your mind, then how will you justify it to yourself first, then to us? So what questions would you ask to justify that this is AVN?
Sir,
So that means you have to think of causes of AVN.
yes, sir.
You have to rule out everything.
Yes, sir. Sir, there was no post-traumatic cause of avascular necrosis in this case. There was no alcoholism or steroid or any condition or any bleeding disorder such as sickle cell anemia, which might be prone to avascular necrosis.
Yeah, Mohan asked you about history of COVID.
Yes.
What is COVID to do with AVN?
Sir, in COVID, it might be treatment related where we give the high doses of methylprednisolone, which might cause the fatty marrow infiltration and cause a hypercoagulable state, which may cause, or in COVID itself, it causes a hypercoagulable state itself. So that might cause
So
lead
you
to
have to ask drug intake.
drug intake.
What other drugs you think of?
No, sir, I mainly asked about the steroids. Steroid drug intake.
Nothing else causes. Who else can get AVN? You said alcoholics.
Yes, sir.
Who is steroid intake? What else?
Sir,
Drugs which affect the lipid metabolism, possibility of can cause AVN. Some of the antiviral drugs also can cause AVN.
Modulators,
Immunomodulators, antiviral or drugs also can cause AVN.
cancer drugs, deep sea divers.
yes.
We have
Yes, sir.
ONGC very close to us.
Yes.
We have many of them who are working offshore. You have to be very sure that you ask all the drug intakes. Now you said tuberculosis
Yes, sir.
is your second diagnosis. How do you justify that? Even to place it at second diagnosis.
Sir, because first is the arthritic component, and secondly, the tuberculosis can affect any age group. So I would like to keep it as a differential, and because India is
Now you have to play between AVN and tuberculosis. No? This is a final match to get your final diagnosis. How do you compare between AVN and tuberculosis in this patient? What else you ask for tuberculosis?
sir, I would like to ask about the any tuberculosis in the past or tuberculosis contact history in the family, and the constitutional symptoms which might not be present as in this case, sir.
Have you asked?
Yes, sir. I have asked about the constitutional symptoms; they were absent, or any tuberculosis history also, sir.
Night pains.
Night cries also, sir. There was no history of night cries. No, sir. It does not have any night cries. Yes. Yes, sir. The patient is well built and moderately nourished. The patient is well oriented to time, place,
Can
and
come to regional examination.
I would like to proceed to my local examination. I have inspected my patient in standing, supine, and prone position. The head is well aligned over the shoulders, and the level of the right anterior superior iliac spine, patella, and the medial malleolus seems to be at a higher level on the affected side as compared to the unaffected side. From the side, there is exaggerated lumbar lordosis, and the alignment of head, shoulder, greater trochanter, knee, and the lateral malleus seems to be well aligned. There appears to be wasting of the quadriceps muscles on the affected side of the thigh on the affected side. On inspection from the back, the patient has the posterior superior iliac spine appears to be at a higher level than the unaffected side, and there appears to be wasting of the gluteal muscles
On right side.
on the affected side, right side. Yes, sir. Now, moving on to palpation, there is no local rise of temperature or any fullness in the Scarpa's triangle. There is tenderness present at the anterior joint line and on bitrochanteric compression. I would like to confirm my inspectory findings on palpation. The femoral pulses are palpated, are equally palpable on both the sides, and there is no palpable inguinal lymphadenopathy. On movements, my patient.
The palpation, you go anteriorly, then laterally.
Yes, sir.
Tell us about the trochanter. No, you should, when
Yes, sir.
you are at a trochanter, superficial tenderness,
No,
deep
no, sir.
trochanteric on
No.
thumping. What is the difference? Superficial trochanteric tenderness. How is the feel? Whether trochanter is a level or it is above. I think you can finish at this.
Sir, on the greater trochanter, there was no irregularity appreciated. There was no broadening or thickening. Superficial tenderness and deep tenderness could not be elicited, but bitrochanteric compression, I could elicit tenderness on the anterior hip joint.
How do you elicit deep tenderness?
Sir, by firmly pressing with the thumb on the greater trochanter, sir.
So what is, when do you get deep tenderness?
Sir, in case of any malunited fracture of the involving the greater.
Only in that case, when do you thump anytime for eliciting deep tenderness, trochanteric tenderness? Superficial is you
But
palpate
side-
the way
yes.
you told.
Yes, sir.
Okay. The deep you would thump, no?
Yes, sir.
Then in which conditions we will get deep trochanteric tenderness? Only in the trochanteric pathology or somewhere else? That thumb will be transmitted
To the yes,
to what?
to the neck and the head.
Joint.
Joint
no?
line. Joint.
So if the joint is affected,
Yes, sir.
you should
absolutely.
have the deep tenderness. No?
Where is the joint line in the hip? Show us.
Yes.
If you are suspecting arthritis, you cannot say that there is no tenderness on thumping.
Yes, sir.
Can you palpate the joint line in the hip?
No, sir. I can localize the joint line, but not exactly the.
Yeah.
Yes.
Anteriorly, where is the position? Which area do you palpate?
Sir, 2 centimeter distal and lateral to the mid inguinal point, we can palpate the anterior joint line.
Scarpa's triangle.
Sir, Scarpa's triangle is formed by the base is formed by the inguinal ligament. The medial border is formed by the medial border of adductor longus, and lateral border is formed by the medial border of sartorius, sir. Yes.
Just, I think Dr. Monte just covered midpoint of the inguinal ligament, mid inguinal point. So these are the FAQs by the examiner. Classical questions.
Yes, sir. Moving on to movements.
So just to emphasize,
Yes, sir.
if you are arthritis, you can't say there is no
Okay.
deep tenderness. Okay,
Yes,
you have to
Okay.
posteriorly in the buttock. Have you seen any?
Sir, I could not elicit tenderness on the posterior.
Okay.
Sir,
Is
on,
trochanter at the are you going to measure? Tell us at later date for the at the time of measurements, or no? The trochanter at the same level, or
sir, during the
during?
okay.
Okay,
Yes.
fine.
Is there any wasting?
So wasting on the anterior aspect of thigh, sir. On the thigh, yes.
What all ways you examine for the wasting around the hip?
Sir, mainly by the measurement and
How? Which muscle groups?
sir, first the quadriceps groups I would like to assess by measuring at a point of the maximum girth, which is approximately 15 centimeter above the lateral joint line.
Understood. What is it? What else?
Sir, gluteus muscles by the asymmetry of the gluteal folds or the flattening of the contour of the gluteus.
On the patient being prone. Patient
Yes,
has
sir.
to be prone.
Prone,
Say
prone.
that first.
Yes, patient prone position, sir. I would there might be asymmetry of the gluteal folds or there is flattening of the contour of the muscles. Continue. Yes, sir. Sir, VMO, I would like to measure at a point approximately 6 inches or 15 centimeter above the medial joint line.
what are the components of vastus medialis?
The vastus medialis and the vastus medialis obliquus. So it is in the lower part. So not 15 centimeter. It will be more distal to it. The way.
You want to be away from the. You don't want to be. You want to be away from the suprapatellar pouch.
Yes.
And also take a level of the where the girth is maximum. Okay, continue.
Sir, on movements, my patient has a flexion deformity of 10 degrees on the affected side, with further flexion possible up to 80 degrees, which is painful throughout the range of motion. Yes. Sir, on this bed, I could not elicit the flexion deformity as it was a 10 degree. I tried on the hard bed and I could elicit the test, sir.
Yeah, but you
Yes,
have not shown us the steps.
Yes.
for-
Yes. Sir.
What are you doing there at lumbar spine?
Sir, I am checking for the exaggerated lumbar lordosis first. If there is exaggerated lumbar
See,
lordosis,
if you have the finding which you have told, you have to stick to the finding. Don't tell on this bed and that bed and all these things. This doesn't look good in the examination.
I've seen people committing some weird that they made the patient lie on the bed on the floor just because it was mandatory that he had to be. It is to be on the hard bed. So don't be so dogmatic about it. Yes. So if you have, it's firm beds.
Yes.
This creates little.
No. Just stop there. Just stop there. Why for flexion deformity you need to see at lumbar spine?
so because the lumbar spine compensates for the flexion deformity by increasing the lordosis.
How much?
Sir, up to 30 degrees. Sir, I'm not sure of the means how much.
What all movements are compensated at lumbar spine area? What all hip joint movement are compensated by the lumbar spine? Flexion, you
Flexion.
told me.
Yes.
What else?
Coronary.
See the same thing, but put in a different manner. And you're so this. I'm just telling. I'm not prompting him to answer. It's the same thing, but he has put it in a different manner.
What
The
all
question.
ways lumbar spine can move? Now this is simpler.
Sir, lateral bend or a
Yeah.
Sagittal
So what is the
Lat-
confusion?
So lateral bend will compensate which the movement, which deformity.
sir, adduction or abduction deformity.
Coronal
So remember
deformity is
that.
deformity, yeah,
Those
correct.
planes you remember:
Yeah.
sagittal plane, coronal plane.
Yes.
Don't try and search catch in every question. Probably it's a simple question. You try to make it complex by hard bed, soft bed. Don't do all that.
This is how it happens when once examiner question you are not able to understand, the other examiner tries to help you. So take the lead from the other examiner.
Answer in words. Moment you make paragraphs, there will be gullies and roads in which examiner can take you. Okay.
Yes.
Sir, monosyllabus. Safe.
Did he say what number
Correct.
Can you pause?
Sir, I would insinuate my hand in the lumbar lordosis. Then I would ask the patient to flex the normal unaffected limb. भैया ये पैर ऊपर करिए. हाँ, ये पकड़ के रखिए.
There are two things. One is
Mobile
do
side
it
ला ठोका.
just enough to obliterate
Yes.
lumbar lordosis. One, and you keep ask him to do this.
Yes, sir.
You keep hand on the pelvis because the pelvis can also tilt.
Yes.
So that you confirm that it is not tilting.
Basic
Flexion
is that
deformity,
you have
yeah.
to stabilize the pelvis.
Flexion deformity किधर है?
Whenever you have a painful hip, if somebody asks you to bend the other hip, will you bend more than that hip comes off? So always bend the affected hip a little. Bend it. Now allow him to flex the normal hip. Okay. This way he'll at least flex it. Otherwise he'll stop the moment that pain starts and you won't get that FFD.
Yeah.
So always bend the affected hip also and then you try and straighten it out.
Yes,
Good
sir.
point. Good. Very good
Yes,
point.
sir. Yes, sir.
Very good point.
10 degree you said.
Yes, sir, 10 degrees.
Okay.
Sir, the patient also has a 10 degrees of adduction deformity.
So when you say 10 degree of flexion deformity,
Yes, sir.
then you have to mention how much is the further. That you
Yes,
said
sir.
80
Yes, sir.
80,
Yes,
80,
sir.
okay.
Further flexion possible up to 80 degree, which
And
was
it's
painful.
throughout.
Yes, painful throughout.
Is there any obligatory external rotation along with it?
Yes, sir. Up
During
to
the
80 degree,
flexion.
I could observe some obligatory external rotation, sir. Yes, sir. With,
What all positions you will measure the rotations of the hip
sir, in
and
the-
why? And why?
Sir, in the flex position of the flexed hip and the extent, in the rotation of the hip.
Rotation of the hip. What all positions the patient you will examine?
Sir, with the flexed hip and the extended hip in the prone position, sir.
Don't confuse. How do you flex a hip in a prone position?
Sir, in supine position with flexion of the hip and in prone position with the extension of the hip. Yes, sir.
So in supine, you can't do extension of the hip.
Sir, it is easier to measure the amount of rotation
So
in the
you
prone
can do
position.
it in supine,
Supine
both
position.
extension and flexion, and in prone in extension.
Yes, sir.
So be clear.
Sir, the patient has a 10 degree of adduction deformity with further adduction possible up to 20 degree as compared to 30 degree on the unaffected side. And this motion is also associated with pain, sir. The patient also has an external rotation deformity of 10 degree with further external rotation possible up to 20 degrees in flexion and up to 30 degrees in extension of the hip. And yes, sir, the movements. On measurements, the patient has a true shortening of 1 centimeter and an apparent shortening of 2 centimeters and supratrochanteric shortening of 1 centimeter as elicited by Bryant's triangle and Nilletton's line, sir. The patient has a wasting of the quadriceps by 2 centimeter. On special,
No. You said you did supratrochanteric shortening by
Bryant's
creating
triangle.
Bryant's triangle.
Yes, sir.
So what are the 3 points of the Bryant's triangle?
Sir, I'll mark the anterior superior iliac spine, the greater trochanter, and I'll draw a line vertical from the anterior superior iliac spine and a horizontal line from the greater trochanter, and the intersection will be the third point. So I'll measure the horizontal limb and compare it to the unaffected side.
Why do you need a totally different point outside the hip to measure the true shortening? Why do you need a hip? Why do you need a point outside? You said ASI is one
Yes,
of the
sir.
points.
Yes.
ASI is not a part of the hip,
Yes, sir.
and you're saying you're measuring supratrochanteric shortening.
Yes, sir. So the supratrochanter part lies between the greater trochanter and the anterior superior iliac spine.
Did you square the pelvis?
Yes, sir. I squared the pelvis and kept it in identical position, sir. The limbs in identical position.
Two prerequisites for measuring true limb lengths. We have to square the pelvis and both the lower limbs should be in the identical position.
I don't think you can miss the word squaring of pelvis
Squaring the
before you
pelvis
start
and
measuring,
keeping both the limbs
and
in
you miss that,
identical
and that's a major thing.
That is for true. And for apparent, both the limbs are parallel to each other, and you are measuring from the Ziffy sternum. Does flexion deformity affect the apparent limb length?
Yes, sir. It will shorten the apparent length.
Continue.
Sir, on
1 minute.
yes, sir.
Why do you need to square the pelvis to measure true length? See, like you don't do positioning of the scapula to measure the length of the humerus. Here you are squaring means you are doing all that thing. Why do you need to just take a point and measure it? Why do you need to have a mirror image on the other side?
Sir, because in this case, we are measuring it from a point above which is not a part of the hip joint. So we need to keep it in identical position so that we get.
So would you say the center of the hip cannot be palpated?
Yes, sir.
And
Yes.
that's why you choose a point
Choose
totally
point
outside
above the hip.
and make mirror image on both sides and
Yes.
then measure.
Yes, sir. Then measure. Sir, on special test, there was negative telescopic test and active straight leg raising test was positive. On examination of other joints, the sacral.
Straight leg raising positive means what?
Sir, means the patient was able to do the straight leg raising test, sir, up to 80 degrees
Patient is able to do active
on his
SLR.
own. Yes, sir.
In which conditions do you test active SLR?
Sir,
Active SLR is a test for which joint?
sir,
If
when
it is
there is,
active SLR is painful, what is the inference?
sir, it indicates that there might be any pathology in the hip joint or
One.
Any other joint?
Any other joint.
Sacroiliac joints
Sacral.
also.
So it's more,
Sacroiliac
more
The
common
hip
for
joint also it is
Yes, sir.
painful
and
because
sacroiliac joint.
the active SLR is as much as 1.5 times the body weight. The joint reaction forces are almost as much as high as 1.5 times the body weight.
Body.
So hip joint pathology active. So this you have to see. You are saying it is arthritis.
Yes,
So
sir.
this is something which is going contrary to your diagnosis that he is able to do active SLR very easily.
Hmm.
So that is going against your that there is no then if it is a hip arthritis, is he able to do it?
Yes, sir. He is able to do it, but it was painful for the patient.
So don't make
Don't
this controversial thing which will which are
Does
contrary
the
to
active
your
SLR
later,
contribute
diagnosis.
anyway to your, in this case?
Sir, if it only excludes the my instability of the hip, like in transavical neck of femur fracture non-union, the patient might not be able to do the active SLR test.
So if you can do union, you can exclude a
No, sir,
non-union?
cannot exclude.
So that's what I'm saying. So does this active SLR add anything to value to your diagnosis? All it has done is sidetracked you off the case. Right?
Yes, sir.
So if it is not adding, why put it unnecessarily?
I think this is for all of them to learn. Anything out of the track you say, and examiners will take you 10-20 minutes. By the time your confidence level will be so low that you won't speak what you know. So I think it should be noted. It's precise. SLR is not something which we are very well versed in hearing in a hip case.
So SLR, I think, are you talking about the spine?
Okay.
So leave it out, the hip case, unless it is essential.
Yes. Sir, examination of the other joints such as sacroiliac joint, spine, both the knees and contralateral hip were within normal limits, sir.
You did not in the
Sir.
you did not mention about the differential rotations in the movements we finished. No? That time I think when we
So
are
now,
talking about
when
diagnosis,
your first diagnosis is AVN,
that is that you missed. See,
so
because
now at the end of your examination, what is your thought process now?
Sir, I would like to go with avascular necrosis of hips, sir.
So of all the findings that you presented, what indicates this is AVN?
Secondary arthritis.
Secondary arthritis due to AVN. No?
avascular
So what indicates this is AVN?
Sir, mainly of the differential rotation which was present in the external
So
rotation.
then
Sir.
if that differential rotation was your crux of making your diagnosis, you have to highlight that we never uttered the word differential rotation whenever you presented the case. That's what sir asked you, no?
So
What happened to
happens is,
differential rotation?
We are presenting in a flow, and then we examiners interrupt for the questions, and then we miss out on these findings. So get well versed with this, so that even when we break you in between, you are again back on the track when we ask you to resume. So that practice, that you have to, that practice you have to get into.
Sir, differential rotation. When I examined the external rotation in the flexion of the hip, it was reduced as compared to the external rotation in extension of the hip, sir.
Why is that?
Sir, because of the involvement of the affected part of the femur head in extension as compared in flexion as compared to extension, sir. Mainly the anterosuperior part of the femoral head which is affected most commonly in avascular necrosis. It was more coming in the way during flexion, sir. Articulates in flexion. Yes, articulates in flexion. Sectoral.
Sectoral.
These are things that you need to say.
Sector.
Say another differentiating point or in the examination, why it is more in favor of AVN and not in tuberculosis? Can you tell me? As regards the deformity, in which stage of the tuberculosis that you have external rotation deformity and adduction deformity? Do you have it? What are the stages of tuberculosis? We can have exception in any situation, but what are the stages? Can you tell us?
So first is the synovitis stage.
So what deformity do you
So
have?
flexion, abduction, and external rotation.
Right. Then next.
So then we get the flexion, adduction, and internal rotation.
Right.
Yes, sir.
And what is that second stage?
So
How many stages are there?
The synovitis, early arthritis, and late arthritis. 4
so-
stages are total. Yes, sir.
So what are the deformities in these stages? First is flexion, abduction, and external
External
rotation.
rotation.
Second,
So flexion, adduction, and internal rotation.
Internal.
In the,
so no stage
Yes,
in a classical teaching.
yes, sir.
No stage we have adduction deformity and external
External
rotation
rotation
deformity, which will be common in 3 conditions.
Yes.
One is AVN, other is say Perthes, and third it will be SCF. SCF is a very rare case. So slip capital femoral episode. You will get abduction restricted and internal rotation restricted,
Yes, sir.
or the deformity in the adduction deformity and external rotation. This is not fitting into the classical stages of tuberculosis. So that is also a point to
Yes, sir.
justify that you would put AVN as a
First.
higher than.
What are the sacroiliac joint tests?
Sir, in this patient, I did the compression and distraction test for the sacroiliac joint and tenderness over the sacroiliac joint, sir. Sir, I couldn't. Yes.
What is the site of joint?
Uh,
How do you surface marking?
Sir, I'll first palpate the posterior superior iliac spine by tracking the anterior superior iliac spine, and then just medial to it, I'll palpate the sacroiliac.
What is the subcutaneous part of sacroiliac joint that you can palpate?
So the ala,
What is the anatomical landmark there?
the posterior part of the ala of the
More precise.
but
Have you seen the dimple?
dimple of Venus, yes, dimple of Venus, yes.
What is Faber test?
So Faber test is the flexion, abduction, and external rotation test, which performed for the sacroiliac joints. I could not perform in this patient because of the lack of abduction, sir.
Okay, now can you now summarize or give a final statement of your diagnosis?
Yes, sir.
in one-
Before summary, Mohanji told you that in tuberculosis, adduction, external rotation, not routinely you see, but when you can see adduction, external rotational deformity in tuberculosis? Sometimes. No. When why there is a, because the ligament bigelow is a strong structure in front. When the ligament bigelow gets destroyed, in extensive tuberculosis, there is external rotational deformity which happens. This is one of the questions which I asked by Dr. Babulkar in one of the senior Babulkar in one of the DNB exams. I still remember this question.
Summarize. Yes, sir, summarize it.
Sir, this is a patient of secondary arthritis of right hip due to avascular necrosis of hip in a 54-year-old male gentleman, sedentary worker by employment, with a flexion deformity, flexion, adduction, and external rotation deformity of 10 degree with shortening of 1 centimeter, currently disabled with activities of daily living life such as ground level activities and pain while walking, sir.
Okay. What
is your provisional diagnosis? Yeah. After finding everything, history, finding everything, before going for investigation.
Sir, my diagnosis would be secondary arthritis of right hip due to avascular necrosis of hip of duration of 1 year, sir. Most probably due to an avascular necrosis of hip of duration 1 year.
So how do you go about it now? What do you want to do?
Sir, I would like to examine him radiographically, sir.
Which X-rays?
Sir, I'd like to get an X-ray of a pelvis with both hip and the lateral of the affected hip, sir.
What do you expect to see on the X-ray and the pelvis with both hips?
Sir, I expect to see the changes of the avascular necrosis of hip, like
Can you
the.
describe? Describe.
Yes.
We are watching here. Tell us now. Does this confirm your diagnosis, and what do you see here?
Sir, on the affected side, on the right side, I can see there is a loss of contour of the femoral head that is flattening. There is a subcondyle fracture, and there are areas of increased.
You have to go in a particular order in X-ray. Either you go from outside in or inside out. When you are talking about inside out now, but first you tell there is increased radiological density or sclerosis of the head, the cyst, then you tell that irregularity, then you go to the joint, then you go to acetabulum, like that. Okay, so in a particular order, you proceed.
Sir, on the affected side, I can see there are areas of increased sclerosis. There are some cystic areas with a subchondral fracture with flattening of the femoral head and reduction of the joint space as compared to the unaffected side, sir. On the X-ray.
Would you still say this is AVN? I say this is tuberculosis. What is the feature? What is the
Yeah,
classical thing about AVN that you have to see?
avascular necrosis and yeah.
Sir, I can see the subchondral fracture, which is the means more.
Is that the first one you will say to sustain your diagnosis of
Bone quality. How is the bone quality? How is the bone quality? How will be the bone quality in the
Sir,
tuberculosis?
it
How
will
would
be
it be?
osteopenic.
How
It will
would
be
it be inflammatory or infective? It will be infective means tuberculosis. I'm talking.
you said
It will be
sclerosis, no?
osteopenic.
I mean,
Yes, it's sclerosis.
Yes.
cyst, sclerosis, fracture.
Yes, sir.
Okay, is there a radiological shortening that you can see? You said there is 1 centimeter shortening. Can you see that?
So the pelvis doesn't seem to be squared, but the level of lesser trochanter is higher on the affected side, sir. So there might be short. It is suggestive of shortening.
And why do you say there is a fracture? What is the pathological course of event that happens to create a fracture there in AVN?
Sir, there is a collapse of the necrotic bone due to resorption.
No, you have to tell me why there is a necrosis.
Sir, necrosis is due to the disruption of the blood supply to the
Disruption. Is that the word disruption of blood supply? It's a fracture.
Sir, occlusion of the
Occlusion
blood
of the
vessels.
vessel.
Yes, sir. It can be intramural or extramural compression of occlusion of the blood vessels, which leads to the disrupted blood supply up to the femoral head, sir.
And that sector, which vessel is that? You kept on saying anterolateral. Which vessel is that? Which undergoes occlusion, as you said.
Sir, the lateral epiphyseal group of vessels.
Lateral epiphyseal, that he wants to say that is in the
Lateral
trauma. That is in the trauma. That is lateral epiphyseal artery branch of medial femoral circumflex.
Yes,
That is usually in the
Trauma.
medial femoral circumflex artery. Okay, that is so now what do you want to stage or something? Is it what is the stage?
Sir,
Any classification? Do you know
sir, Fickett and-
qualitative, quantitative classification?
Sir, qualitative classification, Fickett-Arlet stage 4,
Fickett-Arlet.
4 and quantitative classification, sir, Steinberg grades
Steinberg.
5. 5. Sir.
Now, what would you like to do?
Sir, I would like to get an MRI for this patient to look for the
Before MRI,
contralateral hip.
before MRI,
Yes, sir.
anything else?
Other view of the X-ray.
Other view, the lateral.
Then
Yes, sir. Lateral view.
you must tell that.
Don't jump the gun.
Every hip case, you must tell lateral view.
Lateral.
Don't tell that both hips with upper femur.
What are different ways of taking lateral view of the hip?
So frog lateral view or the cross table lateral view, sir. We can take.
The patient is stiff, hip is stiff. If you cannot do, you cannot abduct at all, then how will you take?
Sir, a cross table.
Any other way? Patient is stiff in neutral
hip.
position.
Yeah.
Even you cannot cross table, you can't get the X-ray tubing in between in the perineum. What would you do? Have you taken Jude views? Something
Yes,
like a Jude
yes,
view
sir.
can do.
Okay.
Especially in ankylosed hips.
Ankle.
Ankylosing bone. So
Bony
you can
ankylosis,
turn
ankylosing
turn the
spondylitis.
pelvis.
Turn the pelvis and do it.
Or false profile view, something like a false profile, standing. So now what would you like to do now?
One second. Why do you take a lateral view? Why you want a lateral view?
So to look for the sclerosed area means to
Sclerosis.
look for the anterior or posterior involvement of the head.
Especially in this particular case, in avascular necrosis cases. Why you want a lateral view?
Sir, to look if the anterior part of the head is involved, there is sclerosis or sclerotic changes or not in the head, which might indicate the sectoral.
What do you notice between AP and lateral?
Something you see which is not there in the AP view.
AP view, what do you see? There's collapse. You've got crater-like structure there. Now see lateral. Do you see that? Can this be of the same hip? And it is some by
Yes, sir,
mistake.
same.
Read lateral. Read the lateral.
Sir, on the lateral view, there are cystic changes present on the superior part of the head, and there are sclerotic changes and flattening of the femoral dome, sir.
Is it?
Yes, sir, some flattening as compared to the opposite side, sir, I could appreciate.
Still the dome is maintained.
Maintained, yes, sir.
Classify lateral, it might be grade 2.
Okay, sir.
So that means there is a sectoral.
Sectoral involvement.
Middle part is involved here.
Yes, sir.
Plus you see the dome coverage of the vestibulum.
Yes, sir.
There is sclerosis.
Sometimes in AVN cases, if you don't find the collapse in the AP view, you take a lateral view, you find a collapse. Okay, that changes your staging. You understand?
Yes, sir.
So that's why I always tell a lateral view.
What is the difference between a post-traumatic AVN and a idiopathic?
Sir, history. There will be a history of trauma in the post-traumatic.
Or pathology. Does it present as the same thing?
Sir, I'm not aware of any specific finding of that.
So this is a sector, no? That will be more global.
Global.
Big collapse, particularly in children. Because the AVN that will be more global.
Global.
Is Shenton line intact?
Yes, sir.
Shenton line intact?
What is center?
Sir, it seems to be disrupted, sir.
क्या बात कर रहे हैं?
It's not always compared to that.
It is not disrupted. I have a,
No, sir, it's intact, sir.
for sure it is not
The
disrupted.
examiner wanted to know whether you know about sentence line or not.
It's intact.
If you tell disrupted, that means you don't know about sentence line.
So now what would you do?
Sir, I would like to I would like to get an MRI to look for the contralateral head, sir.
So contrary, why do you want to do a ear? X-ray is telling you.
Yes, sir.
Opposite hip on the radiology, it is affected or not affected?
No, sir, on X-ray it doesn't seems to be affected, but sir, it might be in the pre-collapse stage 1 or 2.
Is
What is
patient
car-
symptomatic? Sorry. Is the patient symptomatic on the opposite side?
No, sir, patient is not symptomatic.
Just for the devil's advocate, I'm just arguing. Why do you want to? Suppose you find it in a pre-collapse stage 1.
Yes, sir.
Patient is asymptomatic.
Yes.
So now, is
Will it affect the management of this
Sir,
patient?
It will not affect the management of the affected hip, but we might be able to do something to prevent the collapse of the contralateral hip, sir, or the unaffected hip.
Is that proven? Of the unaffected hip in stage 1,
So there are no,
asymptomatic.
What is Carbon's index?
sir, Carbon's index is the we measure the angle of the necrotic area of the hip in the mid sagittal and mid coronal view of the MRI, and we add the angle in the mid sagittal and mid coronal view. If it is less than 190 degree, it is supposed to be low risk for collapse, and more than 200 degree, it is suggest of high risk, sir, for collapse.
No, any additional information on the MRI? Can you put the MRI there for the benefit? Yeah.
So you do MRI for the opposite hip, not for the same.
Plus, skip that coronal view.
No,
Correct.
T1.
So I can confirm my diagnosis on the X-ray. So for the same hip, MRI is not absolutely necessary, sir.
Okay. What is the diagnostic sign of avascular necrosis on the MRI? Where
Sir,
you cannot have any other differential, it is only the sign.
Sir, it is a double density sign.
Double
which is
density sign.
seen on
What
the
is it?
T2
What the benefit of here? Those who do not know here in the crowd, can you tell us? What is-
Sir, in the double density sign on the on a T2 weighted image, we can see an hyperdense and a hypodense lines, which are the double density. The hyperdense line indicates a granulation tissue, whereas the hypodense indicates a sclerotic bone. So that is pathognomic of the avascular necrosis.
So now,
In T1 or T2?
Sir, T2 weighted images. Sir,
yes. Now what do you want to do? No.
Sir, I would like to plan my management after counseling, after conferring with my patient, what are his expectations,
Other investigations, basically.
other hematological investigations. Sir.
To rule out any other
Yes.
cause, sickle or blood dyscrasia,
Yes.
other things. And then
Sir,
you consult the patient. Yeah.
yes, sir.
For what?
Sir, for this patient, I would like to offer him a painless, stable, and mobile hip, and ask what the patient wants. As the patient has a sedentary lifestyle, I would like to go for a total hip replacement in this patient, sir.
So when you said he was affected, that he couldn't sit on the floor and he couldn't use a Indian toilet,
Yes, sir.
he still goes for a job. So how is your total hip going to make it better than what he already is?
Sir, it will relieve the pain that
So
he
if
has.
if his expectation, I want to sit on the floor.
Sir, ground level activities will have to be modified even of the total hip replacement, sir, but it will provide him a painless hip so that he can at least walk without pain. And if we, in later stages, it might also involve the other activities if we don't treat the patient.
What other activities?
Means it will become more, the symptoms will more deteriorate.
Why this is he right a time for a total hip replacement?
Yes, sir.
Is he getting so much pain that he is significantly not able to do his job? You said he goes for a job every day.
Yes, sir.
Is he taking any painkillers?
Sir, on and off medication, but not regular
So
medication.
not regular
Not
medication. So what is the indication for doing it? At this stage, I'm not saying you can't do a total hip. At this stage, is there an indication for doing it?
Sir, to prevent the further deterioration of symptoms.
Yeah.
Will that
So
affect?
the
will-
indication for total hip is pain.
so are you doing it
and
to
pain.
stop in
Discipline.
arthritis progressing?
It is
Or are
not
you going for
profound.
pain relief?
Pain relief also.
So that's what I'm
Pain
saying. So does it matter if you do it later on?
No, sir, pain.
No.
Never.
No,
To
sir.
be frank,
No, sir, it will
no.
not matter.
No.
It will not
If
affect
it is
the-
disabling,
So the-
pain is interfering with his day-to-day activity. It is disabling. It is affecting the quality of life.
Yes.
Perhaps we can offer him earlier as well, because we know it is a longer term survival
Yes.
of this. 6 months here and 6 months later, it's not going to matter.
Never tell that prevention of deterioration of
Prevention,
symptoms.
that is
You are
wrong.
not doing
That
totally.
answer. It's not
Totally-
prophylactic surgery.
Totally was pain.
Yes, sir.
Pain at rest, pain at night, pain which hampers activities of daily living.
Yes, sir.
Okay,
Which-
that is the indication.
Which hip? We don't reach this stage in the exam, but now since we are at this.
So what hip replacement are you going to
What
do?
is, how do you select the implant? Prosthesis.
Now,
What is the prosthesis of choice?
now
What-
you are heading for gold medal. So, sir is asking now about
what is the
further
prosthesis
questions.
of choice?
You are passed now.
This question is a ghanti to let you know that you are on the upper scale now. Now don't make a funny mistake, okay?
Now, don't make blunders.
Sir, my decision will depend on the bearing surfaces which I'll choose. Sir, for younger patients, I would prefer the ceramic.
These are always
talking
this
about
particular
this,
patient.
You have to speak of the patient who's in front of you. You're not talking theoretical now.
Sir, the best
For this
treatment.
patient, what are you going to do?
Sir,
You
the
are a
best.
consultant. You have to decide in consultation.
So the best modality would be to go for a ceramic on ceramic, but metal on polyethylene.
What will
will
you
also-
do?
Your choice. Your
Doctor,
choice.
now I will do this.
And
with
then you
this
defend.
bearing.
I will-
And you defend. You know, for this.
That's it. I can do.
Sir, I will go for a ceramic on ceramic hip, sir.
So I would do an uncemented.
Uncemented ceramic on ceramic total hip
Okay,
replacement. Sir.
okay. So that is the answer that you have to give. You can't say I can do. You can do a lot of things.
Yes, sir.
Will you do a cemented hip in him?
No, sir. No, sir.
Why?
Why not?
Sir, because
Okay.
so because the bone quality of the patient was good, and I would like to calculate the dose ratio to look whether I have to go for a cemented or an uncemented.
Door ratio is good. Still you will do cemented. I mean, it's bad. You'll do cemented.
Yes. Sir, in door 3, I would go for a cemented total
C.
hip replacement, sir.
Door C.
Sir,
Here examiner differs.
So what happens is you can, the jury is, you can say politely, the jury is still out. There is a debate, but you can put the advantages of this, pros for this. There are pros and cons for everything. The pros for doing this is so this and this. The jury is still out. The debate is still out. So you can say it politely. Okay. Debate will be there at different levels and different.
You should know the salient features of defending uncemented and cemented. Okay. You should know the knowledge should be good enough to defend both.
So
But you say stick to one thing. And
what I would-
that won't be taken as arrogance.
Okay.
You stick to, because as you said, you're a consultant. You can take a decision,
And
implement,
I would
execute.
suggest that rather than putting a negative points of the cementing, you would put positive,
Positive.
points of why you are doing this. Don't, because he may be a cemented man, so he will take it as offense. So you put in a positive. I would, in my personal experience, I have seen this, and this is why I would do it.
Okay.
Though jury is out, and we can always do that. But I would prefer to do this.
I want to ask a simple question. You said you will ask the patient what does he expect.
Yes, sir.
He is a farmer who wants to do fields, wants to do tilling and
Yes.
digging. He doesn't have in Western toilet. What would you offer him?
Sir, I would like to go for a salvage option rather than a sacrifice
Salvage.
option. Sir, mostly I would go for an arthrodesis. We can go for an arthrodesis.
Farmer can do with an orthodontist. He will do farming.
Sir, he will be able to bear weight, heavy weight, or
With a diagnosis of AVN, how easy will it be to get a arthrodesis?
How did I
See,
Already you have got AVN, no?
Arthrodesis doesn't solve his problem. I'm told
They don't have Western toilets there.
sir, it will provide him a painless immobile hip, but he will be able to do the manual labor in that case, sir.
See, even in these conditions, right, you don't want to sound very arrogant, but okay. You don't want to sound very arrogant, but if you want to defend, and you take overall the way the things are going, so we can still defend the hard on hard bearing. It is better lubricating. It is a joint for many decades. They will go on, and even if you have to make them sit cross, down, though you would not encourage it, it would permit. It would not increase the wear rate of the ceramic on ceramic as much as if you would have done on hard on soft wearing. Hard on soft wearing, soft will bear faster, but the hard on hard wearing is the this thing for years together. We talk about the decades, so even that can be allowed. The sitting cross-legged, though I would not encourage them to do it.
Thank you, sir. Thank you, sir.
Thank you, Dr. Rajan. Thank you.